Good evening, everyone. We'll just give it a couple of minutes to make sure people have a chance to log in. Thank you. Okay, thank you. I think we will get started. Good evening, everyone, and thanks for taking the time to join us for our third Sienna, Ontario Resident and Family Town Hall. We recently marked 1 year since the beginning of the pandemic when we found ourselves, and we now find ourselves at a critical and complicated juncture. While the vaccine rollout and slowing numbers of outbreaks signal hope, new variants are posing additional concerns that may prolong the pandemic. And as we have before, we wanted to provide you with an opportunity to hear the most current information directly from our medical professionals and to get answers to your most pressing questions. With so many participants on this webinar, we're not able to open it up to live questions. However, we did provide an opportunity for you to submit your questions in advance. And thank you to everyone who submitted questions. They were very helpful in shaping the content for tonight. We'll start the meeting with updates about current COVID-19 cases, variants of concern, and the vaccines, as well as an overview of what we're doing at Sienna to manage the pandemic and prepare for wave 3. And then we'll get into your questions. And for those, we took the most frequently asked questions from the survey and combined them into themes, hoping that we touch on most of the questions that are important to you. Unfortunately, we can't answer individual questions related to your loved one in our residence or to your own personal health situations. So we do ask you to please reach out to your residence team or your family physician for those answers. Now I'd like to introduce you to our guests for this evening. Dr. Andrea Moser is Sienna's Chief Medical Officer. She's a family physician with a focused practice in the care of the elderly, a certified medical director, and an associate professor with the Department of Family and Community Medicine at the University of Toronto. She has an extensive background and interest in the care of seniors with a focus on long-term care medicine and has been an advisor to the Public Health Agency of Canada, among other organizations. At Sienna, Dr. Moser is focused on enhancing the medical and physician support provided to our residents, as well as supporting our management of the COVID-19 pandemic and preparing for any potential future outbreaks. We are also joined by Dr. Allison McGeer, Chief Infection Prevention and Control Consultant to Sienna. Dr. McGeer is the premier infection prevention and control specialist in Canada. She's a professor in the Department of Laboratory Medicine, as well as the Department of Pathobiology and Public Health Sciences at the University of Toronto. And she advises multiple levels of government on pandemic prevention and management, including Canada's National Advisory Committee on Immunization and the Infection Control Subcommittee of Ontario's Provincial Infectious Diseases Advisory Committee. With Sienna, Dr. McGeer has played an important role in guiding our teams to effectively manage outbreaks and prevent further spread of the COVID-19 virus, as well as preparing sustainable plans for the future. Now we'd like to begin, and I'll turn it over to Dr. McGeer to go ahead with her presentation.
Thanks very much, Maureen. Okay, so I put the bad news up on the screen. So let's stop for just a moment with the good news. We are having substantially increasing numbers of cases in Ontario. Things in general are really not good news overall. In the face of that, we are not having long-term care home outbreaks. And so what that's telling us is that our vaccination programs in long-term care are holding against the current variants. Most of what we're seeing is the one called B117, which is from the UK. We're still watching very carefully because the P1 and B351, where we're a bit more worried about vaccine efficacy, are coming. And so it's not a time to just be relaxing and saying everything's going to be okay. But it is truly amazing that with the B117 and with the number of cases in the community that we are not seeing cases in long-term care. So I'm going to take a moment to thank everybody who's on this call for having their loved ones in long-term care vaccinated, for getting vaccinated themselves, for supporting Sienna staff through the vaccination program. It's really quite wonderful after such an awful year. However, in the community, there's just no denying in Ontario that we are in very significant trouble. And you see on this graph, the blue lines are what we now call the original variant. So the first strain in China and the first variant of that. And you can see now that the increase is all in the orange. The orange are variants of concern. As I said, mostly the UK variant, the B117. And so if you look at the next slide, can you do the next slide, Maureen? There you go, okay. You can see that we're maintaining the old variants, okay? They're stable at about 700 cases a day. They're not going anywhere. But on the orange on the left, you see this dramatic increase in the new variants of concern. And it's that increase that has driven us from 1,000 cases a day about 10 days ago to more than 2,000 cases a day this week. And if we don't do anything, we'll be at 4,000 cases in about 10 days and about 8,000 cases 10 days or 2 weeks after that. This is that is an exponential increase, not a linear increase. So we are almost certainly going to be forced into some form of lockdown in Ontario to preserve our intensive care unit beds and to prevent younger people from dying. One of the big problems with these variants is not only are they more transmissible, but they are also more likely to result in hospitalization and death, and the people who get them are younger. So we're starting to fill our ICUs now with people who are in their 40s and 50s and 60s, and that situation is only going to get worse. Next slide. And this is just a comparison this week from Ontario Science Table. So if you look on the left side of this at 2,236 infections averaged over 7 days, that's where we were on December 26th when we went into lockdown. And you see what you expect to see after lockdown, which is you lock down now, you still have to wait 14 days to see the cases that happened were transmitted before the lockdown that just haven't started. So the case rates go up. This week, we exceeded where we were on December 26th in terms of numbers of cases. And you can see in the yellow line, in terms of hospital cases, we're already above the number of hospital cases and above the number of ICU cases. So we are certainly going to be in trouble with our ICU capacity and with our hospital capacity in a matter of 2 or 3 weeks. This is, of course, particularly difficult for a number of reasons. Firstly, we're all tired of the pandemic and we just want out of it. We delayed March break in Ontario so that we could have a break in April because we were hoping it was going to be better in April. And now it turns out to be worse, which means that politicians are going to have to make a tough decision about what's happening on March break. And those of us who might have been planning to travel on March break are now probably not going to be able to. So the short term, this is all bad news. The slightly longer term is that, right, what's gonna beat this in the short term is us going into some form of greater restriction to preserve our healthcare system and to prevent people from dying in the next month or 6 weeks. What's going to get us beyond that are vaccines. And we're now at about, next slide. I'm hoping I've got these slides on it. Yeah, so here's where we are in vaccines. 2 million people in Ontario have been vaccinated. That is 86% of everybody over the age of 80 in Ontario has had at least 1 dose of vaccine or has a booking for vaccine sometime in the next 10 days. Okay, now, it would be better if it were 100%, okay, and our, you know, that the vaccine bookings have been really difficult to organize, which I think is mostly why it's not 100%, but it's still really good news. We are delivering vaccine to people at the highest risk. It is going to make a significant difference. And vaccines are coming more and more quickly and will move really quickly into younger age groups, but that's not going to happen for another month or 6 weeks. So we have to get through this very difficult period in the next 6 weeks until we have enough of the high-risk people vaccinated to be getting out of our difficulties in the ICU and in hospitalizations. Next slide. Okay, one quick question, because there's been a lot of backing and forthing about AstraZeneca vaccine, and you know, I think those of us who live and die by pandemics and vaccination programs knew that there were going to be all these bumps in the road, but it feels, I think, just like one more thing in this awful mess that just won't go away and won't stop, that we continue to have issues with vaccines. So the quick summary of AstraZeneca vaccine is that in terms of protecting you from serious illness, it looks very similar to Pfizer and Moderna. There's been a bunch of discussion about Pfizer and Moderna are better, and really, they may be better at preventing asymptomatic infection spread, but they're not better at preventing serious illness. So of the vaccines we have available in Canada, whatever vaccine you're offered is the right vaccine to have just at the moment. This week, we're having a lot of discussion about the potential complication of blood clots associated with the AstraZeneca vaccine. There are still a lot of uncertainties about it, and that's to be very frustrating, but to be expected. This is a very rare occurrence, okay? So we're still a bit uncertain about the number, but somewhere between 5 and 9 per million doses. So when you have a small number of cases spread over a large number of countries, putting the information together, making sure you have it right, understanding what's going on is really challenging. It's what we pay public health people for, and they're working on it, but we do need to give them a little bit of time to figure out whether this is really caused by the vaccine, how the vaccine does it, whether it's specific to a batch of vaccine or to this vaccine or to viral vectored vaccines. All of those things are still a question. For those of us who are older, anybody over 60, very clearly that rate is low enough that your risk of COVID is significantly higher, and getting vaccinated is the right thing to do. For 20-year-olds, on the other hand, you can get really sick with COVID, but it's really unusual to die from COVID if you're 20 to 29. There have been 2 deaths in Ontario from COVID in 20 to 29-year-olds. So now you're talking about a risk of something serious happening 1 in a million. That may be low, but it may still be a higher risk than COVID, which is why NACI has said that for the moment, not vaccinating people under 55 with the AstraZeneca vaccine until we sort this out, because we don't want to be taking risks. So need some patience while we figure out exactly what the right thing to do is with the AstraZeneca vaccine. But for older adults, still a very sensible thing to do. Next slide. Okay, and this is just to remind people about what we know about the efficacy of these vaccines. This is an analysis from the United Kingdom. The United Kingdom's had many more cases per capita of COVID than we have, so it's good from that perspective to be in Canada as opposed to the UK, but they've done a remarkable job of getting data for us on all sorts of things, including how well vaccines work. So this is a comparison of the Pfizer vaccine and the AstraZeneca vaccine after the first dose. Okay, and you can see that they're almost identical. So 70% effective in preventing any infection. And then additionally, if you do get infected, 60% effective in preventing you from having to be hospitalized or dying from COVID. So overall, if you're over 70 and you get either one of these vaccines, one dose of either one of these vaccines, for at least 3 months, there's about an 85% protection from hospitalization or death due to COVID. Okay, not 100%. Okay, so you just can't go out and party with all your friends forever, but 85%, which is a really substantial reduction and obviously a great benefit, and really again, no difference between these vaccines. Next slide. Okay. So what's the balancing act then in terms of thinking about making sure that we protect residents, team members, essential caregivers in long-term care? As I said, everybody's still anxious about B351 and P1 because these are places where the vaccines may not be as good and where there is still the potential for outbreaks in long-term care. So we have two problems with what's coming from the province in terms of directive. The first is this uncertainty about these new variants. And the second is the problem associated with the fact that what public health is focused on at the moment is our hospital capacity and our ICU capacity and on getting vaccine out, okay? And they're just so grateful that we're not having outbreaks in long-term care that it doesn't feel as essential to them to get long-term care open as it does to all of us. And that just requires some patience to get through. They're working on new directives. We were just having the discussion that this will be the first time we're actually looking forward to a new directive because it's going to help things move again, but we are going to have to wait. In Ontario, you see the first move already from the science table that we've recommended not doing asymptomatic screening of vaccinated team members. And so that's a step in the right direction. And as you'll see when Dr. Moser is talking about it, the other things to remember are that anything you can do outdoors is significantly less risky than things that are done indoors. And that we still really want as many people as can figure out how to access vaccine to get vaccinated, because how far we can go in reducing the precautions depends on how many people are vaccinated. Next slide. Okay, now just a quick note on accessing vaccine, because I honestly really thought we were going to do better than this in Ontario. But there are 3 ways of accessing vaccine if you're not fortunate enough to have a family doctor who's in the program. The first is the website to book a vaccine. You go into that website, you enter your postal code of your public health unit. It'll tell you who's eligible in your local area because the age bands are a little different in different places. But essential caregivers and personal support workers are eligible all across the province. And you go through and enter your health card number, and then it'll show you clinics that you can book in. You have to be a bit careful because some clinics are open some days and other clinics are open other days. And so you got to spend some time working your way through it. And twice when I've gone into it to book things for people, it's just refused to accept a postal code, or this morning it refused to accept somebody's health card number, which was fine. However, the 1833 number has also worked pretty well. This morning I got through, you have to listen to 5 minutes of somebody telling you stuff, but then we got through it, and it was really quick and very efficient. If you're in an area with one of the big academic hospitals that have clinics, the hospital vaccine clinics are running their own bookings separately, so you can Google your hospital clinic and log in and get to it. And if you're 60 to 74, there are participating pharmacies in some area of the province, and you just have to go pharmacy by pharmacy looking to see where they have vaccine. And I think I'll stop there and transfer it over to Andrea.
And my internet just told me my internet is unstable. So hopefully the joys of COVID with everyone on technology. So thank you for coming tonight. And again, we're going to talk about what we're doing at Sienna to prepare for wave 3. I think we all wish we weren't having this conversation and that we could say wave 2 was settling everything down and we were now, summer was coming and we could all get outdoors, and we're really, as Dr. McGeer said, watching these numbers pretty closely. I think the good news is that we're seeing really great uptake of the vaccine. So at the current, those are our summary in Ontario. We have 93% of our residents in long-term care have had at least one vaccine. I believe it's around 90% have had the second dose of the vaccine. So that's a really great news story. Retirement residences are lagging a little bit behind because they didn't have access at the same time the long-term care. However, 95% of those residents have had their first vaccine. It's a lower number for the second, but we're still really encouraged by this. Our team members in long-term care are at about a 70%, and that's actually higher than the provincial average. We're really encouraged. We're seeing continued uptake of the vaccine by our team members. So we're hearing a lot about what we're calling vaccine hesitancy, people who are a little bit cautious, and they may have a variety of very valid reasons for that cautiousness, but as they talk to their colleagues, as we have one-to-one talks with those team members, we're seeing that number increase. We had one care community this week alone that had it was about 50%, and part of the reason for that number was they had a lot of staff who really wanted the vaccine but had trouble accessing it. So the public health department in that area came on site, and that home is now up to 80% with its vaccine. So lots of work being done. We're tracking it regularly. We're trying to understand what are the reasons for the variation in the numbers in each care community, and then we're strategizing on how to support those homes. So the team at Sienna is working really hard on this, and with the support of Dr. McGeer, getting that education and resources out. The other thing that we've started, as I'm sure those of you who are essential caregivers have experienced, we're doing the active on-site screening for our team members and for our essential caregivers. It's really running smoother than I think a lot of us thought. We thought this was going to be a really difficult thing to implement, but the staff are really motivated to do this and are really happy to see this in the communities, and it's going really well. We now have great supplies of PPE. If you've been in any of the care communities lately, you'll may see mountains of PPE. We actually at some point have to bring some back to the storage because we've overstocked in some care communities. So that's a good news story, to have more than what we need, and we have ample supply of all types of PPE that are needed. The infection prevention and control measures are ongoing. Enhanced cleaning is ongoing, trying to keep down clutter, trying to make sure that we're washing off surfaces. We do have, with some pandemic funding, we were able to obtain some new furniture in some of the homes that is more, it's less porous, so it's easier to wipe down with some of the wipes. So you may see what looks like a bit of a refresh in some of the care communities as well when you go in. And then we continue to follow all of the directives, all of the recommendations, liaising with our public health departments, and following our guidance. So next slide. So we'll just talk a little bit about currently what we're doing in our long-term care. Our protocols, again, we have recommendations from the government, public health, medical officer of health. Now that we're in colored zones for now, that if you're in a green zone versus a yellow zone versus an orange zone versus a gray zone, things will be slightly different. So that is quite a bit of work to track and make sure we're getting it right, but we're working diligently on that to make sure that we're following those recommendations. We continue to allow essential caregivers in. We've had some discussion about this with the lovely weather starting to show up and beautiful days, and we know how long this has been for the residents in our care community, that those essential caregivers, if you come in, we're now you know, opening up that outdoors to you, so you can take your family member, your loved one outside and for a short outdoor visit. That may be limited again in different care communities based on the environment and space, so we can allow that outdoor space, but we still have to maintain and support all of those IPEC measures. So wearing a mask if possible, wearing, you know, an eye covering, having physical distancing. So if you have to go down an elevator, you know, 6 people can't be in the elevator, all of those things. So there may be schedules that have to be set up to support those outdoor visits. No general outings at this point, other than that going out with a caregiver. And we still have to have a 14 isolation if people are admitted to hospital and then come back to the care community. Our dining and indoor activities, we're again monitoring those and adjusting those, opening up, and particularly as we're seeing more vaccination of our residents, we're able to have some of those groups start up again in limited numbers, as well as the dining may be able to open up a little bit more. And then some of those things that a lot of us haven't seen for a long time, hair care, some of those third-party services. So again, as things hopefully you know, keep going, we may be able to see those. I think one of the things we're all you know, watching closely is when that next directive comes out and what impact is that going to be on our residences, and what does that mean in the context of long-term care where we have a very high vaccination rate. Is there going to be some different type of recommendations made? We all know how hard it's been for everybody over this past year, and so being able to have family members visiting our residents, we know how critically important that is, and all of the staff and we all would love and would be quite joyful to see all of our visitors coming back into the homes, but we just want to make sure we're making smart decisions and keeping everyone as safe as possible. The next slide. I'm going to talk a little bit about some other things that we're working on. So again, we're going to try and do some of the activities to get people outside a little bit. So some gardening may happen, some patios being used. Again, whenever we're doing these things, we're going to ensure that it's still a small group. We still have to have the physical distancing. So depending on the care community, it will be different activities that we may be able to start doing again. That hand hygiene, all of those things that we're just all doing every day, and even if you're vaccinated, we still have to keep doing it. So the hand hygiene is critical, the physical distancing is critical, wearing the mask, keeping the mask on, making sure it's above your nose, all those things, right? We just have to keep doing it. Even if you're outdoors, to wear a mask. And with our residents, we know not everyone can tolerate a mask, but we're trying as best as possible. And I've been out to a few care communities over the past couple of weeks and really quite impressed at how many of our residents are actually able to wear a mask and doing it quite well. And there's others that they're just not able. So again, we have to be flexible with that. There may be some outdoor entertainment so that people can hear and have some of that entertainment to see. I heard there was a community where there was a daycare that came and was, I think they were doing drawings or something outside, and the residents were watching from the windows. And so again, just being flexible and creative. And again, as we talk, the essential caregivers to go outside with your resident, weather permitting, and as long as our directives don't change on us. So next slide. We know that there's a lot of holidays, special holidays coming up in the next few weeks. And so we've already had questions about, can I send my family member flowers? What about deliveries? So that's, again, to know that those are continue to be permitted. If you're bringing in homemade food items, just try to put them in a plastic container so they can be wiped down. And if there is something that the residents is concerned about, they may ask you to not bring that in. Hopefully we can all work together on that. The other thing is, if you're bringing items in, just make sure that they have the name of the resident and the home area. That just helps us to make sure it gets to the right place. And also with the flowers, just make sure that those also have a clear label on them. And then we all just will ensure that we're using good hand hygiene whenever we're delivering any packages. Okay, I think we're now at the questions. Maureen.
Hi, thank you. Thank you both for all of the information that you've provided. And just as a reminder to everybody, we did take all of the questions that you submitted in advance, and we kind of collected them into different themes so that we could touch on those most important topics that you put forward. There was a question also in the chat asking about a specific residence and for updates on that residence. And I just wanted to, again, also remind everyone that this is a broad and general town hall meeting for family members of all of the Sienna long-term care communities and retirement residences in Ontario. So we won't be providing updates on specific residences. So I'm sorry if there was confusion there, but we just wanted to provide this overview of wave 3 and the variants and what's currently going on with the pandemic. So moving over to the questions, one of the main topics that came up was around testing and whether all long-term care communities have rapid testing. Why was the move made to rapid testing? And why do some have a combination of both? So maybe we'll just touch on the first set of questions first. Dr. Moser, is that something that you can speak to?
Sure. I think there's a lot of reasons for the rapid testing. Again, this was something the government really felt strongly that we should be doing in long-term care to move away from the PCR testing. It's on site, so it's certainly more accessible to people. We heard that there were some people who really had difficulty getting the PCR testing. It's not an easy test to tolerate. The rapid testing is a little bit easier to tolerate. It's just at the what we call the anterior nares. They don't have to go all the way back like the PCR test. It allows you to get your answer right in real time. With the PCR testing, we know there's always a delay of 24 hours or 48 hours. So if we are testing team members on a Monday and they don't get the result back until Tuesday night, that's a long time if they're working for those 2 days in the care community. So again, it's trying to stay on top of that and trying to make sure anybody who is positive or potentially positive with COVID is not coming into contact with the residents. So that's the reason. It also gives us the ability to test other people who are coming on site. So contractors, people who, again, part of their job, they might not usually be doing PCR testing, so that might delay their being able to come on site to do repair work or jobs. Some of the long-term care homes with a combination of PCR and rapid testing takes up some human resource capital and people. And so there are some homes where if they're just really having trouble with enough staffing, they're not able to set up the rapid testing on a daily basis. So they're able to do a PCR test once a week and then a rapid test as a second test during the week. So it's evolving, and then hopefully over time, if that happens, they may be able to do more rapid testing with time. Once a home is declared in an outbreak or a suspect outbreak, public health may then direct us back to doing the PCR and not doing the rapid testing anymore. So it's going to be a little bit confusing over the next little while. So you may come in one week and it's a rapid test. The next week they may say it's a PCR, and we just have to go with the flow on this and figure it out as we go. And as with everything with COVID, we have a plan on how to do it, and then we learn more, and then we adjust that plan, and then we learn more, and then we adjust that plan. So for now, It is the rapid testing. It's going well. You know, we're encouraged so far. I don't know, Dr. McGeer, if you had anything more to add to that?
No, I don't think so. This is one of those circumstances where we really are dependent on a decision at the ministry level about what the recommendation for testing is. I think that the science table is convinced that we can stop testing people who are vaccinated, but that the ministry is now looking at the data, and we'll see hopefully the end of this week or next week what they think about it.
Okay. And so that, I guess your responses would answer the last question as well. When can we reduce the frequency? So sounds like we're waiting to hear from those experts. So maybe we'll move to the next set of questions around team member vaccination. So we've touched on that a little bit already, but so we've provided the vaccination rates for team members. Dr. Moser, can you talk to what we're doing for any new team members for vaccinations? And I think you've already touched a little bit on what we're doing for education and encouraging vaccination as well. Maybe you can review some of that.
I think, so the answer is yes, team members will continue to be offered vaccine, continue to be offered education on vaccine. And again, it's coordinating how they access that vaccine. So setting up, you know, are they able to go into a vaccination site even before they start work? Or are we having vaccine come onto the site? But this is absolutely something that is top of mind with anybody who's coming into the care communities.
Okay. Can either of you respond to the topic of mandating vaccines for team members, and why we would or why we wouldn't do that?
So maybe I can start with that. The question about mandating vaccination for anybody, not just team members in long-term care, is related to whether that vaccination is essential for the protection of people that they care for. So that's where we have rules about being vaccinated against influenza or not working during outbreaks or being on antiviral prophylaxis. But the problem at the moment with even thinking about mandates is that we don't have enough information to know whether vaccination of team members is necessary for the protection of residents. Vaccination of team members is obviously really important to protect the team members, but just at the moment, the vaccination of residents is working extraordinarily well to protect them from significant illness. And as long as vaccinating residents alone protects them well, then it actually doesn't matter whether the team members are vaccinated. It obviously matters to the whole community whether team members are vaccinated. But in terms of preventing outbreaks in long-term care, we may not need to worry about team members. It may be that the only people who need to be vaccinated are the residents, because if they're vaccinated, they're well protected and they don't need a layer of coverage, right? The reason that we worry about influenza vaccination in long-term care homes is because residents are not well protected by our current influenza vaccines. They're just not very good vaccines. But the vaccines against COVID are actually great vaccines, and they work well. Now, there's an open question because we don't know how long the vaccines protect you. We're not sure they're going to protect you against variants. And obviously, we want team members and entire communities protected. So we're going to keep working at getting team members protected, but it may not be something that even needs to be mandated. Then there's a secondary issue about how difficult it's been to require vaccination of people. And there are good reasons why people are worried about requirements for vaccination, but that's a secondary discussion. Now, I see something in the chat that you're absolutely right, that At the moment, if a team member tests positive, everybody goes into precautions. And that again is something that we're hoping we'll see a change in the next week or two. That change requires a change in decision making at the provincial level. It has to come from the ministry to not go into the whole building, not go into precautions when a team member is diagnosed with COVID. And so when that happens, and it's going to happen because it's very clear now that if you have a team member who has COVID, that is not resulting in outbreaks throughout the facility. So we don't need everybody in precautions, but we will have to wait. So you're right. It is an issue currently. But the fix for it is not to require that team members be vaccinated at the moment. The fix for it is to recognize that we don't need to have everybody in precautions in the building just because one staff member has COVID with our current vaccination rates.
Okay. Thank you for all of that. We'll move on to the next group of questions. So this relates to the second dose of the vaccine. With the extension of the time frame between doses, several related questions to that. Is it safe and effective? Does it provide adequate protection? What evidence supports the decision to extend the time frame? Does it put seniors at risk? And how does this impact residents at Sienna? So Dr. McGeer, can we start with you on to address those topics?
Okay. So let's try taking these questions one at a time. There's nothing wrong with extending the period of time between doses. Doesn't mean it actually means you react better to the second dose than if you get the dose earlier. So that's good. There's no safety issues with it at all. You don't have to restart. If you wait too long, you don't have to have an extra dose of vaccine. The only issue is that so the first question is, are you as well protected after the first dose for the first period of time? And does that protection wane before you get the second dose? So the first question is, for the first couple of months after you get one dose, how well protected are you? And then do you need the second dose to keep up the protection out to 4 months? For the first dose, it doesn't protect you quite as well as having 2 doses. So the estimates are 95% with 2 doses, 85% against serious illness with 1 dose. That is a difference, and it's a reason why we'd like to give everybody 2 doses of vaccine on schedule, but we don't have enough vaccine to do that now. So what public health has now is a choice between getting 85% protection to 100 people or getting 95% protection to 50 people and leaving the other 50 people unprotected. And in that situation, clearly it's better to get 1 dose into more people. The best analogy I've heard is from one of my family physician colleagues who said, when I'm not getting my second dose, I feel like I've had my first dose, that's my meal, okay? The second dose is like having a cupcake for dessert. And I'm being asked to give up my cupcake so that somebody else can have the meal. And that's very, that's very clear. There's not a question about whether we should do that. The relevant question is, can we delay for as long as 4 months? And we don't know that yet. That's why everybody is saying up to 4 months, because we're watching to see what happens. The place where we'll see it likely is in Quebec and British Columbia, where long-term care residents have only had 1 dose of vaccine. And if they start to see outbreaks or cases, then we'll know that we need that in the most vulnerable, we really want to get second dose vaccines in. And then we will move to people who are over 80 and people on dialysis and people who are immunocompromised as the people who respond least well and are most in need of a second dose of vaccine. So if it's delayed beyond 2 or 3 months, there may come a place where it's putting seniors at risk, but people are watching very carefully, and we're going to change our mind. And if vaccine deliveries keep up the way they're supposed to, then it's almost certainly true that we'll be able to move up a lot of those second doses from July to June. And so people won't actually have to wait the 4 months that we're thinking about waiting now. For residents in Sienna long-term care, no impact. Everybody's, the agreement is that long-term care residents are getting 2 doses, and essentially everybody has had 2 doses. For retirement, it's maybe not quite so clear. We're still working on getting 2 doses to everybody, but I think we are probably still going to hold on to getting 2 doses to all retirement home residents, but they haven't been prioritized by all the health units, as all the health units are balancing trying to get vaccine to people in outbreaks and get vaccine to older homebound individuals and essential caregivers. And so retirement homes, I think in some places have fallen a little bit behind on their second doses, but they are supposed to come. And really, you're very well protected after the first dose. So it's a matter of days after the second dose. You have to wait 2 weeks after the first dose to have a substantial amount of protection, but essentially as soon as you get the second dose, you are well protected.
Great, thank you. Dr. Moser, anything to add on that?
No.
Okay, thank you. So we'll move to the next group of questions. So following the vaccine or vaccination, and a person has received both doses, do you think that general visits and outings can resume at that point? Can I visit without PPE? Can I touch or hold my loved one? You know, what do you see happening? And I think we've touched on that in various ways so far in the evening, but perhaps you could go through some of that again. Dr. McGeer, I don't know if that's something you can speak to.
So again, I think we're just starting, but yes, and outings hopefully will start up in the short term. And people will be able to come in without PPE. It has not quite happened yet, but hopefully that change is going to happen. Part of the reason it hasn't happened yet is because no vaccine is perfect, right? So we're talking about vaccines that have 85 or 90 or 95% efficacy. That's not 100. Okay, it's 85 or 90, and the protection against mild or asymptomatic infection and transmission is still somewhat uncertain. We're getting more data every day. It's looking better, I have to say, every time we get new data. So it's all good news, but we really still want the evidence to be that if you have had the vaccine, that you have the same reduction in risk of transmission to other people, and we just aren't quite there yet. In terms of the vaccine protecting against variants, the vaccines we're using are just fine against our most common current variants. So most of our infections now are the B.1.1.7 variant, and vaccines work very well against that. Still some questions about how well they work against P1 and B.351, and we're waiting for data now. Your antibody levels against those variants are not quite as good. It doesn't look like the difference is big enough to make a significant difference to protection, but we still don't know that.
Okay, thank you. We'll move on to the next group, and I think there might be a bit of duplication here, but you know, kind of this is the last grouping of questions with, you know, what is on everybody's mind is when will we see changes and when will things open up more? So I think you've touched already on the first question there around freedom to visit our loved ones or bring them home. But the second one, what has to happen in order for protocols to be lifted? Are there certain things that public health is looking for? Can either of you touch on that?
I think so. So I think two things. The ministry has to change directives, and I think there are three things that are making that process slower than we would like it to be. The first is that it's been such a tough year, and people are afraid that, you know, if they lift restrictions, that the outbreaks will start again, and that fear doesn't even have to be completely rational, right? It's just so good to be in a place where there aren't outbreaks, and it's so scary to think about removing precautions that at a system level, we know we're slower than we ought to be about releasing precautions. The second issue, which is real, is these new variants and the concern that we may not be protected as well against the newer variants as against the one that we're dealing with mostly now. And the last thing we want to do is release the precautions and then say, oh, geez, no, sorry, everything has to go back. And the third issue is that, as I said, governments are really at the moment occupied with trying to get vaccines into people's arms and watching what's happening in healthcare and trying to make sure that hospital and ICU capacity can manage the increase in illness. And I think that's just slowing down how much time and energy people have to rethink the protocols and the directives for long-term care. It isn't a really satisfactory thing. I think a piece of that is it's in the nature of pandemics that these are difficult things. It's not the ministry trying to be difficult. But it's admittedly taking longer than we would like it to for these decisions to get made.
Okay. Would you mind, Dr. McGeer, clarifying which of the variants what the variants are by, I know you've got the names that you love with letters and numbers, but where they originate from, just so people are clear?
Yes, I'm really sorry. You know,
that's okay.
We're not supposed to be naming things after countries, okay? We agreed definitively, okay, after the swine flu or actually before the swine flu in 2009, that we were not naming vaccines after countries, because you watched what happened with President Trump and the China vaccine, the China virus, right? It really is, it's discriminatory and hard on countries. So we've all been told we're not to use country names, but the alternative to not using country names is you use these completely incomprehensible numbers that we've assigned them. Okay, so the B3117 is what we call the UK variant, first recognized in southeastern England. P1 and P2 are the Brazilian variants that are causing a lot of havoc currently in Brazil. And B351 is the South African variant, which is the one where we're most worried about the potential for vaccines not working quite as well.
Okay, thank you for that clarification.
And I see a question about testing. So yeah, everybody who's tested in Ontario now is getting a second test to look for variants. And if those variants are identified, the public health unit knows, and the person who's infected, and if it's related to long-term care or hospital, the hospital or long-term care home will know if it's a variant. Yep.
And does the rapid testing also, it doesn't detect the variants,
No,
right?
You're right. It has to be a PCR test. The rapid
Right.
testing you can't use to detect variants.
So if I'm correct, the rapid test will show that you've got a positive, and then you're moved over to, you're directed to get a PCR test. Is that correct?
Yep.
Okay. I'm just going to see if there are any other questions we can address quickly while we have a couple of minutes left to go. Have any of the variants appeared in a Sienna home? Do you want to, I know both of you can speak to that.
Yes,
Dr. Moser?
yes, they have. And right now, I think we're hearing over 50%. I think it's higher than that now, of the people who are positive with COVID in Ontario are with the variant. So it's quite likely that we will continue to see the variants. As we said, it is picked up by the PCR testing and by the PanBio testing, and we we are informed when it is a variant. And the percentage of team members, we are at 70% was the number.
And a 70%, I think, in long-term care, and a little bit less in retirement.
Yeah.
And then transmissibility after getting the vaccine. I think someone was looking for clarification on that, Dr. McGeer.
Yes, so I think the answer to that question is you're right. We still don't, we're gaining confidence that after you are vaccinated, you are less likely to transmit the virus. But what we want is a number for that, right? Preferably a high number for that. And we still don't have enough data to be able to put a number on that risk yet. We know it's better than not getting vaccinated, but we still don't know how much better.
Okay. Doctor, I don't know what the answer is to this one. If somebody can go to visit their loved one without having any kind of COVID test, if they're visiting outside.
My understanding is you still would need a COVID test, but we haven't had directives for outdoor visits in long-term care right now. So that's my understanding. And again, as we learn and as that is updated, we certainly will communicate that with you.
Okay.
There also was the question about what protocols change. And I think I spoke about that earlier, that if there is an outbreak, the rapid testing changes back to the PCR testing. And all those isolation precautions get implemented much more rigorously in terms of isolation and caddies outside of the rooms and all of the things that happen when there's an outbreak.
Mm-hmm. Okay. And are you able to touch again, Dr. Moser, on some of the education and the work being done to provide team members with confidence around the vaccines if they have not had it yet?
Yeah, so education, access to peers who have had vaccine, connection with community groups as well. And then also making sure that we have access to the vaccine. So when staff do agree that they would like to take the vaccine, making sure that we have it available to them. We report on our vaccine numbers, so that's tracked and reported to the province as well as internally. And then we're individually having conversations at each home to determine what are the specific factors. There might be a different issue at home that we then have a different strategy to work on. So there's a vaccine task force at Sienna that is actively working on trying to find every way possible to increase people's confidence in taking the vaccine.
Public health has also been in some homes to do education. The Ontario PSW Association is holding regular webinars for people from outside. There are also some other webinars being run through people from U of T that are there just to try to get some education from external people, so it doesn't feel it's like Sienna management telling people what to do, but rather getting referrals to the appropriate information about vaccines so that you can know enough to be able to make a decision.
Okay. And what does presumed outbreak mean? And I think the other term is suspected outbreak. If you can explain that.
So it's a mechanism at the moment to allow public health units in some circumstances where they have a single case of COVID in a staff member of long-term care to not put the entire home in outbreak. The current definition says that if you have any one person, staff member or resident, that the home has to go into outbreak. But as we've learned, there are circumstances, particularly now that everybody's vaccinated, where you don't need to do that. So when you have a case, the public health unit has the ability now to not call it an outbreak. Different public health units are making different decisions. Obviously, the circumstances of when the infection happened and who got exposed may also make a difference. I see there's a question about why is a home on presumed outbreak not listed under homes in outbreak. That's a public health decision. But I also think, honestly, if you're in Toronto and Peel region, we've been having a lot of difficulty keeping the outbreak lists actually straight. And I have found a number of errors in the list, which is just a function of public health people being way too busy and not having had enough sleep for a long time. They're not quite as reliable as they used to be, although they're getting better now that we don't have so many.
Great. So I think we're at time. We're at 8 o'clock. Thank you, Dr. Moser and Dr. McGeer, for spending the time with us and sharing all of your insights and information. And thank you to everybody who took the time to attend as well and listen to these updates. We hope that it was valuable and useful. And I'm glad we were able to respond to some of the questions that you put into the chat as well. Oftentimes we don't have time to get into that. So tonight's video will be uploaded onto the Sienna website, and the link is there for you. So if you know anybody who wasn't able to attend, who would like to see this, please direct them there. We do have other videos there as well, some which are only a couple of minutes long, which answer some of the questions that have been on people's minds. So we look forward to seeing you hopefully again, maybe not too soon. Hopefully we won't have a reason to have another one of these too soon, but thank you again, everybody. It was a pleasure to be with you, and enjoy the rest of your evening.
Thanks, everybody.
Good night.
Thanks, everyone. Good night.